Okay, it's a pleasure to introduce our next speaker, Dr. Sandro Rizoli, who's a good friend of mine. He's originally Brazilian, but we've claimed him as Canadian now. He did his medical school and residency initially in Brazil, then came to Toronto in '92 for fellowship. Did his fellowship, and then went back and retrained in general surgery. Also did his PhD at the same time, and has had a very distinguished career at the University of Toronto, where he now is professor of surgery. He's the chief of surgery, chief of trauma at St. Michael's Hospital right now. His major research interests are in the evaluation of hypertonic saline, both the immunologic as well as clinically, and now he's shifted that a bit more to the coagulation in trauma and utilization of blood products. He is now the CIHR Novo Nordisk New Investigator. He's received that award. He's been awarded the D'Souza Research Chair in Trauma, and it's a pleasure to have Sandro come give this talk.
So, good afternoon. First of all, thank you very much for the invitation to come here. I really appreciate that. Thank you. It's an honor to be here. So, you have my time. So the question I'll try to answer is, so one thing that changed in trauma resuscitation in the present century is that now patients with significant bleeding are resuscitated with blood, red blood cells and plasma in a ratio of 1:1. That was a major change in resuscitation. The question is there anything new in this century on how we use blood for trauma patients? And the answer is there are many. I'll focus on 4, and that will be my talk. So here are my disclosures. Let's start with the basics, things that everybody knows. So everybody knows that trauma patients bleed a lot. And the bleeding is the first cause of in-hospital death after trauma and the most preventable cause of death. We also know that there are 2 types of bleeding. There's the mechanical bleed, meaning there's a hole in the aorta. Right? The best treatment for mechanical bleed, it's you. You take the patient to the operating room and you put a stitch in there, right? So that's the treatment for mechanical bleed. And then you have coagulopathic bleeding. Coagulopathic bleeding is an organ dysfunction. The clotting system doesn't work. That's systemic bleeding. What this patient needs in general is blood and a few other things that you can do, but those are different types of bleeding. So that makes resuscitation of a bleeding trauma patient a challenge. And I consider that resuscitation today is a mixture of science and art. When you're resuscitating someone who's bleeding to death, there are many things that you have to do at the same time. You have to stop the bleeding, first of all. You have to restore volume, as we just heard now, and that's a challenge, right? Well, how do you restore volume? And then, at the same time, you have to correct the anemia that's happening there. This is different from anemia in the ICU. There's all the novel evidence on, should I give young red blood cells or should I give old red blood cells? Does that make a difference when I resuscitate my patients? And so on. And our patients are a metabolic mess, right? So resuscitation of someone with significant bleeding is art and it's science at the same time. So let's talk a little bit about 1:1. So the first reports of using red blood cells and plasma to resuscitate patients with major bleeding came from the war in Iraq. We start hearing around 2004 of some soldiers that would die either way being resuscitated with 1:1. And they survived. And we like that. And many trauma centers, particularly in the US, in North America, start using 1:1. And all of a sudden we start hearing a lot about patients surviving massive bleedings. And then later on, there was the PROPER study. The PROPER study was the randomized controlled trial designed to show whether 1:1 was in fact the best way to resuscitate someone with bleeding. And the PROPER was not a slam dunk. Right? The PROPER was published in 2015 was a massive study. It included 680 massively bleeding patients, involved 12 trauma centers in the US and in Canada. And the major conclusion of the study was there's no difference in mortality if you measure mortality at 24 hours or 30 days if you use 1-to-1. It showed it reduced mortality if you measure mortality at 3 hours. It reduced the number of patients dying from bleeding, but the main outcome, the primary outcome, showed no difference. And this raised many questions and made many of us rethink whether 1-to-1 was the best strategy. The fact is that even before PROPER, we had already changed. I think that today in North America, the standard of care is that if you're dealing with someone bleeding to death, you resuscitate them from the start with red blood cells and plasma. At least you aim for a ratio of 1-to-1, and you try to restrict crystalloids. It doesn't matter if you like PROPER, if you don't like PROPER, that's the standard of care, right, in North America. And I would say that today, if anyone arrives hypotensive in a trauma center in Canada or the US, they're going to get blood. I'll tell you that, right? So what's new? Besides 1-to-1, is there anything new that has been added? So as I said, 4 things. And those are the things I consider more important. There are tons of other things. So let's talk about, one is how we understand trauma coagulopathy. That has changed enormously. In the 20th century, when I did my first residency in general surgery, we thought that coagulopathy was something that was iatrogenic, was dilutional. It will happen late, right? It took a while to happen. Came a paper in 2003 by Brahe, and he showed no, patients actually become coagulopathic immediately after the trauma. They don't have to be cold. You don't have to dilute them. So actually coagulopathy is something inherent. It's a response, it's an immediate response to trauma, and it's often associated with shock. So that was the first thing that we learned early in the 21st century. Another thing that we learned is that coagulopathy in trauma is not something simple. In fact, those are thromboelastograms from multiple trauma patients that were bleeding. And if you notice there, half of the patients who were bleeding had a normal thromboelastogram. 1/3 of them had hypercoagulability. In fact, many of our trauma patients are overclotting, and they're bleeding, right? While about 25% of the patients are hypocoagulable, and they can't clot. And one thing that we learned by using thromboelastograms is that actually there are some patients who actually have something that I never even thought before, something called fibrinolysis. Actually, they form a clot, and the clot dissolves very quickly. And if the patient has fibrinolysis, usually about 70% of them will die in the next few hours. That's something that we did not even consider. And what we have learned is that what happens in trauma coagulopathy is that a natural anticoagulant called protein C is activated in response to trauma. And when you activate protein C, 2 things happen. You anticoagulate this patient. That's why our patients don't stop bleeding, and you cause fibrinolysis as well too. But I wish things would be that simple. It would be just APC, right? Because then we could come up with a drug, anti-APC drug, but it's not that simple. So there's also many other mechanisms involved in coagulopathy, such as endothelial damage, glycocalyx degradation, and blah, 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 and platelet dysfunction, and so many other things. And to make life more difficult even, we have learned that also things change with time, meaning that the coagulopathy defect that the patient has now may not be the same that the patient will have in 3 hours from now, right? And still, one of the challenges that we have as surgeons that we like to think in compartments. We like to think this patient's missing platelets, this patient's spleen clotting factors, this patient's missing fibrinogen, when in fact things are much more complex than that. And one of the examples is thrombin generation, and I will not make you go to sleep by talking about thrombin generation. I just find that thrombin generation is the one who makes the clot stable. So if you don't produce enough thrombin, your clot's going to be unstable and more likely to be broken down. by lysis. But what's interesting about thrombin generation is that thrombin generation lags behind the clot being formed. So how can something that happens later affect how the clot is formed? And that's things that we're trying to understand. And so I would say that one of the major changes that happened recently is that we have learned that coagulopathy in trauma is not simple. It's complex. It involves multiple mechanisms, and it changes over time. Is that okay so far? Okay. So that's number one. And then all of a sudden you as a clinician turn to me and say, why do I care, right? Why do I care that APC is the key thing? Why do I care that things change over time? And the reason why I think you should care is because that changed the way you resuscitate your patients. If there are multiple mechanisms causing coagulopathy, that means that not everybody needs plasma. So if we're giving plasma to everybody, that may be incorrect. Not every patient needs plasma. Maybe your patient needs fibrinogen. If things change over time, means the patient you're treating now, 2 hours later when they are bleeding, they have a different problem, and that you may not be addressing correctly. So I think that I was part of 2 consensus conferences, and both the agreement was it's okay to start treating a patient who's bleeding to death with 1-to-1, right? You blindly give them RBCs, platelets, and plasma. But as quickly as possible, you have to find out what is wrong with this patient and treat what is wrong, or you have to customize your resuscitation. Blind racial resuscitation is acceptable to start when you have someone who may die in the next few minutes. But as quickly as possible, you need a diagnosis of what's wrong, and you know that the usual lab tests like INR, PTT, and fibrinogen are very limited, and they are not good to help us in trauma. They were never designed to be used in trauma. So what many trauma centers are using nowadays is actually thromboelastometry. Many of us are trying with thromboelastometry, and one of the beautiful things about this lab test is that it can give you information on what exactly is wrong with my patient. Is there something wrong with my patient? Is there a coagulation defect that needs plasma? Or is there a coagulation defect that needs platelets? Right? And the beautiful thing that I like about Rotom is that while if you have someone with an INR of 3, it means absolutely nothing, right? A patient with INR of 3 doesn't mean this patient is bleeding. So there's no correlation between INR, PTT, and the clinical presentation of your patient, while Rotom is different, or TAG, right? They're 2 equipments that are very similar. I talk about Rotom because that's the one I use in my hospital. But the beautiful thing about Rotom is that if you have any abnormal test, probably your patient is bleeding. So there's a good correlation between the test and the clinical presentation of your patient. And the second thing is that it can tell you how to treat this patient. And the third thing that I think is important for Rotom is that it's the only test that will diagnose fibrinolysis. Right? There's no other test in practice that will diagnose fibrinolysis. And as I mentioned earlier, fibrinolysis in trauma carries a huge mortality. So these are the 3 steps to interpret Rotom. I think the only 3 measurements that you really care if you're a clinician. If the CT is prolonged, means this patient needs plasma. If the amplitude is small, brief, means this patient needs probably fibrinogen. And if the patient has lysis, this patient needs TXA, right? Needs tranexamic acid. And that's how we have applied this test to my hospital where I work. We have this machine in the lab, and we can see in real time the result of the test in the trauma room or in the ICU or in the operating room. And what we have there, we have made a pocket card that we hand to all our residents, so then they have no excuse not to use the Rotom during their resuscitation. And we have also reviewed our own data in there, and we have found that there's a good correlation between an abnormal test and the patient dying. There's a good correlation between abnormal test and the patient needing transfusion, needing massive transfusion. Right? So, and if you're still not convinced about goal-directed Resuscitation, I would recommend reading this paper, just published like a few weeks ago in Annals of Surgery, headed by Gonzalez, and it comes from Dr. Moore's lab in Denver, that basically they did TAG-directed resuscitation of trauma patients with a significant difference reduction in mortality when resuscitation was guided by TAG. So, but I would say it's not TAG, right? It's just a different mindset. So when you're doing racial resuscitation, when you're doing one-to-one, you're flying blind. I think that another major change in resuscitation has been the emphasis that not every bleeding is the same. You may be giving plasma to a patient that needs platelets. So you have to customize your resuscitation to the patient that's in front of you at that specific time. And the only way that you're going to do that is unfortunately by doing lab tests. And Rotom at this time and TAG, I actually tested help a lot. They are far from perfect, right? Far from perfect. But I think it's more the idea that the best resuscitation, in fact, goal-directed resuscitation or customized resuscitation. Okay? So two more, I think, big advances recently. One of them is the importance of fibrinogen. So if you're hearing this talk on the internet and you're from Europe, probably this is nothing new to you, but I think that for a lot of us here in North America, we don't pay much attention to fibrinogen. Why the Europeans think that actually resuscitation should start with fibrinogen, not with plasma. So the European guidelines for resuscitation of massive bleeding actually says not only to correct fibrinogen, but correct to high normal fibrinogen. And the fact is that fibrinogen is essential for coagulation and is the first clotting element to drop. And how do you know if your patient has low fibrinogen? Very simple. If they are hypotensive, about half of them have low fibrinogen. If they are anemic, if their hemoglobin comes back around 10, that means that 3/4 of them, 3/4 of them, 75%, have low fibrinogen. If they have a high SS, 100% of your patients have low fibrinogen. And if you have low fibrinogen, you're not clotting well, and your chance of dying have increased significantly. The PROMIT study was a study done here in the United States, and it showed that here, usually we only think about fibrinogen about 2.3 hours into the resuscitation. In Canada, it's even worse. We usually take in Canada about 4.5 hours before we call for the first unit of cryoprecipitate, and that's probably because we don't measure fibrinogen and we don't think much about fibrinogen. So I think that the third major advance has been that fibrinogen is very important. And you will not correct fibrinogen by giving plasma. You have to give fibrinogen. You have to give cryoprecipitate. And if you don't measure fibrinogen, or if you don't do TAG and Rotom, you're not going to know if your patient has low fibrinogen or not. And the last point is tranexamic acid. I think there's very solid evidence that tranexamic acid reduces mortality in trauma. There is, however, a fascinating novel hypothesis that was generated again by Dr. Moore's lab in Denver, that maybe not every patient will benefit from TXA. There's a lot of new papers on fibrinolysis shutdown. My take out of that is that still the best evidence from CRASH-2, from MATTERS, from a lot of even non-trauma studies is that TXA reduces mortality. So I consider that a level 1 evidence, and I consider that enough for me to give TXA to every trauma patient that's bleeding, but there's actually some new hypotheses that are coming up that may change that. So that's the end. So a lot of things have happened with the use of blood and bleeding in the 21st century, besides one-to-one. We're understanding coagulopathy much better. Now we all have this idea that this is not a simple coagulopathy, right? This is not hemophilia. Hemophilia is simple. Hemophilia is a simple clotting factor that's not working. Trauma coagulopathy is much more complex. There are multiple mechanisms, and it changes over time. It changes, right? So I think that the key things is the idea, the concept that you have to customize your resuscitation to the patient that's in front of you. pay attention to fibrinogen. Fibrinogen is a key element in coagulopathy, and also consider the use of TXA. There's actually very good evidence that TXA, who's safe and very inexpensive, reduce mortality in trauma. Once again, it's a privilege to be here. Thank you very much for this opportunity.
We'll take some questions from the audience, and also remind people online to go up to that top right-hand corner, click the question button, and please enter any questions. Dr. Notrika.
Thank you. So, Sandro, I don't get it. So why, if people are bleeding, why do some people need platelets and some people need fibrinogen? We're all bleeding out whole blood. Why is there so much variability between people?
You got it. So it's the basic answer is we know so little about coagulation, so little, that we're so ignorant that the maximum we can do today is to say they're different responders, right? Maybe it's different time. So maybe the hypercoagulopathy that we see in about a third of our patients is physiologic. Maybe it's normal. Maybe when I'm starting bleeding, my clotting goes in overdrive. So when we get in those patients, it's actually phase 1 maybe of the bleeding. And when we see them hypercoagulable, it's phase 3 or phase 4 and so on. The fact is that we don't know. And we know that protein C is a key element. When we measure protein C, we found it to be very high in patients who were coagulopathic. But why do those patients activate that response and others don't? And the fact is that we don't know, but we know that patients are different. And when we're resuscitating them, we have to be cognizant of that, and we have to give the treatment that the patient needs that minute.
We have received a lot of questions here.
Okay, great. Excellent.
So the first one is, if you have any commentary about what do you think is the difference between use Rotom and TEG for resuscitation of the polytrauma patient?
Okay. So none, and I have no conflict of interest here too. I'll declare that. I personally have used more Rotom, and one of the reasons is because it has a software that allows me to link it to my hospital electronic data, so then I can collect the data into the patient's chart immediately, while the TAG 5000 didn't have that. I know there's a new model of TAG coming up, the 6S, that will change that. So I think that in practice, for the clinician, I see no significant difference between them both.
We'll get just 2 more quick questions here, then to the audience in a sec. What dosing of TXA are you recommending?
I would say follow the CRASH 2, so 1 gram and then 1 gram an hour later. The difference that I do in my hospital is that we give boluses of TXA. We give 1 gram bolus and we give 1 gram bolus 2, different from the CRASH 2, who the second dose give over 8 hours infusion. I find that if you do that, a lot of times the TXA end up in the garbage or not given.
And the last question online is, what about fresh whole blood in a civilian trauma patient experiencing severe hemorrhagic shock?
That's also a challenging one, and we could be here for a few hours talking about fresh whole blood. It's a great proposal, but in practice I find it very, very difficult to implement.
Yes.
Jason Brill from here in San Diego. So thank you very much for bringing us up to date on resuscitation. I do have a question about using TEG and Rotom to guide therapy. I personally am a believer, but there are naysayers, especially when you have a patient who is bleeding out in front of you. You think that you've stopped all of the mechanical bleeding and the TEG returns with all normal parameters. Do you have a backup or an algorithm that you use for addressing those patients?
I would say that all lab tests have limitations, right? I remember recently reading a study on INR comparing with, and saying, look, INR is actually not that bad. The problem is that there are certain patients where INR doesn't fit. And I think the same thing with Rotom too. Rotom's a good test. I think it adds to INR, PTT, and fibrinogen, and platelet count. But I think it's far from perfect. It's actually a bad test. It doesn't measure platelet function well. It doesn't tell you if the patient is taking anticoagulants. And sometimes patient is bleeding in front of our eyes and the Rotom is normal, or vice versa. So I think that we have to take everything with still, I say resuscitation is art and science. It's still the best thing is a clinician who knows how to interpret a lab test in face of the patient that you're treating there. That's the best arrangement.
All right, that's great. Thank you very much, Sandro.
Thank you.